Atypical pneumonia, also known as walking pneumonia, is the type of pneumonia not caused by one of the more traditional pathogens. Its clinical presentation contrasts to that of typical pneumonia. A variety of microorganisms can cause it. When it develops independently from another disease, it is called primary atypical pneumonia. The term was introduced in the 1930s and was contrasted with the bacterial pneumonia caused by Streptococcus pneumoniae, at that time the best known and most commonly occurring form of pneumonia. The distinction was historically considered important, as it differentiated those more likely to present with typical respiratory symptoms and lobar pneumonia from those more likely to present with atypical generalized symptoms and bronchopneumonia. Distinction between atypical and typical pneumonia, however, is medically insufficient. For the treatment of pneumonia, it is important to know the exact causal organism. Terminology: primary atypical pneumonia is called primary because it develops independently of other diseases. Atypical pneumonia is atypical in that it is caused by atypical organisms. These atypical organisms include special bacteria, viruses, fungi, and protozoa. In addition, this form of pneumonia is atypical in presentation with only moderate amounts of sputum, no consolidation, only small increases in white cell counts, and no alveolar exudate. At the time that atypical pneumonia was first described, organisms like Mycoplasma, Chlamydophila, and Legionella still were not recognized as bacteria and instead considered viruses. Hence atypical pneumonia was also called non-bacterial. In literature, the term atypical pneumonia is still in use, though incorrect. Meanwhile, many such organisms are identified as bacteria, albeit unusual types. As the conditions caused by these agents have different courses and respond to different treatments, the identification of the specific causative pathogen is important. Signs and symptoms: usually the atypical causes also involve atypical symptoms, no response to common antibiotics such as sulfonamide and beta-lactams like penicillin. No signs and symptoms of lobar consolidation, meaning that the infection is restricted to small areas, rather than involving a whole lobe. As the disease progresses, however, the look can tend to lobar pneumonia. Absence of leukocytosis. Extrapulmonary symptoms, related to the causing organism. Moderate amount of sputum, or no sputum at all. Lack of alveolar exudate. Despite general symptoms and problems with the upper respiratory tract, there are in general few physical signs. The patient looks better than the symptoms suggest. Cause: the most common causative organisms are bacteria, Chlamydophila pneumoniae, mild form of pneumonia with relatively mild symptoms. Chlamydia psittaci, causes psittacosis. Coxiella burnishier, causes Q fever. Francisella tularensis, causes tularemia. Legionella pneumophila, causes a severe form of pneumonia with a relatively high mortality rate, known as legionellosis or Legionnaire's disease. Mycoplasma pneumoniae, usually occurs in younger age groups and may be associated with neurological and systemic symptoms. Atypical pneumonia can also have a fungal, protozoan or viral cause. In the past, most organisms were difficult to culture. However, newer techniques aid in the definitive identification of the pathogen, which may lead to more individualized treatment plans. Viral when comparing the bacterial-caused atypical pneumonias with these caused by real viruses, the term atypical pneumonia almost always implies a bacterial etiology and is contrasted with viral pneumonia. Known viral causes of atypical pneumonia include respiratory syncytial virus, influenza A and B, parainfluenza, adenovirus, severe acute respiratory syndrome and measles. Diagnosis: chest radiographs often show a pulmonary infection before physical signs of atypical pneumonia are observable at all. This is called occult pneumonia. In general, occult pneumonia is rather often present in patients with pneumonia and can also be caused by Streptococcus pneumoniae, as the decrease of occult pneumonia after vaccination of children with a pneumococcal vaccine suggests. Infiltration commonly begins in the parietal region and spreads in a wedge or fan-shaped fashion toward the periphery of the lung field. The process most often involves the lower lobe, but may affect any lobe or combination of lobes. Epidemiology: Mycoplasma is found more often in younger than in older people. Older people are more often infected by Legionella. References